Good morning, everyone. One more lecture about hemostasis. And in this lecture, we are going to cover disorders of primary hemostasis. And my plan is to basically cover in this lecture disorder of primary hemostasis. In the next lecture, we are going to cover disorders of secondary hemostasis. And once we will cover that, then one lecture will be about hypercoagulable states, and in hypercoagulable states, we have already covered DVT and thromboembolism. So after that, like, there will be just malignancies will be left. So once malignancy, so like you can say, another 3 to 4 lectures after our hematology will be finished. So disorders of primary hemostasis, if you like, you had done my previous lecture of you can say the introduction to the hemostasis. So what is primary hemostasis? As we know, there are two things which play the key role. One is platelets, and one is like one Willebrand factor, right? And one Willebrand factor is released from the endothelial cells. So, and I was telling you again, like the platelets can be decreased or the platelets can be abnormal, like normal level, but of course, like the action is not normal. So simply, this is like primary hemostasis can be simply defined as or disorders inability to form or an adequate platelet plug. Okay, so of course it could be a disorder or some problem in the. Okay, so like we will go for the classification. How we classify that classification. Okay, classification simply can be done um, of classification of causes of primary hemostasis disorder. See, number one, the problem or the pathology can be in the platelets. As you know, like the platelets can be normal, can be low. Number second, there can be von Willebrand VWD problems or disease, von Willebrand disease, in which von Willebrand is not present, and vascular problems. Okay, vascular. Number third reason can be vascular problems, vascular problems. So talking about the platelets, for example, what can this one we have already covered, by the way, in the previous one. I told you either it could be low platelet count or it could be normal platelets, right? We have already discussed this thing. What are the low platelet count things? I told you it could be either it is not produced at all, aplastic anemia, either there is increased destruction like immune thrombocytopenic purpura or thrombotic thrombocytopenic purpura, either it can be hemolytic uremic syndrome, for example, in which also platelets are also destroyed, heparin-induced thrombocytopenia, or for example the spleen is destroying more, or for example in the case of splenomegaly. Okay, so these are the causes. So see, decreased production, increased destruction, that's it. And when the platelets are normal, what are the things we have already discussed? um, uh, there could be acquired problems, there could be hereditary problems. I told you one thing called as Bernard Solier syndrome. What is that one? In which there is glycoprotein 1b deficiency, so the platelets cannot attach. And the other one I told you is Glanzmann syndrome. In this one, which one is there? Glycoprotein 2b3a is deficient, so the platelets cannot attach with each other. And there can be many acquired causes like drugs, like aspirin. Okay, uremia, I told you, in which the platelets are not functioning normal, um, and so on and so forth, right? There are other causes as well. Von Willebrand disease is a disease, guys, which in these patients there is less von Willebrand. So we will go for the vascular. Now, vascular problems. This is a new thing for you guys, for you people. There are many hereditary problems, hereditary issues. There are many acquired issues. Same thing here, hereditary and acquired. Okay. So if we'll talk about the hereditary issues, there could be connective tissue disorders, CTDs, connective tissue disorders, in which the vessel walls are abnormal, and that's why they can bleed more, or they cannot clot properly. One of the syndrome called as Osler Weber Rendu syndrome, or hemorrhagic telangiectasia. In this one, the people, they have multiple malformations and they can bleed easily. Acquired form is Hinox-Collian purpura, for example. Scurvy, if you know, scurvy, deficiency of vitamin, which will lead to bleeding. Cushing syndrome is one of the cause in which the patients can bleed more. Infections, drugs. There is a condition called as purpura simplex. These are the people who can bruise easily. Okay. So many drugs, they are associated with thrombocytopenia, especially low platelets like heparin, digoxin, rifampin, ethambutol, even ethanol. There is a lot. Okay. Immune thrombocytopenic purpura, guys. There are two types. It could be primary, it could be secondary. It can also be classified as adult or childhood. Okay. Now, there could be adult ITP, there could be childhood ITP as well. So, see, these are petechias. Why? Because like the immunity, they basically destroy the platelets. So there is no point of giving platelet transfusion, because if you are going to give platelet transfusion, what will happen? They will be destroyed as well. Petechia onychomosis, bleeding from the gums. Okay. So the important thing in this one is what, like in immune thrombocytopenic purpura, childhood one, of course, it occurs in children. Adults, of course, it occurs in adults, and the adult one is more common in females. Okay. In childhood ITP, we usually found a history of recent infection. Okay, and after that infection, what happens? Like the immune system get triggered, and they started destroying more and more platelets. So the duration of these kind of condition is like within weeks. The babies, the children, they started, like the condition is get improved and their platelets come back to normal. Okay, most of the patients, their platelets come back to normal. The only thing we get worried about, like when the platelets count is decreasing, I'm not showing you more things because we have already covered the sick in pediatrics, but just for revision basis is like the only thing we are worried about, like, is like any intracranial bleed or any excessive bleed should not happen. So we keep on checking their platelet levels, and if the platelets are decreasing too much, so we can put them on steroids or things like this, or we can admit them in the hospital. And like one of the thing, or like if the platelets are less than 20,000, of course something must be done. In adult type of ITP, one of the thing is that, like in children, 80% of the cases, the remission occurs uh, itself, but in adult ITP, most of the patients, they run a chronic course, months to years. Okay, so adult and childhood ITP, there could be primary or secondary. Okay, of course, primary, in which no cause is found, so it is called as idiopathic thrombocytopenic purpura, and secondary is of course secondary to certain conditions like SLE, systemic lupus erythematosus, are written over here. It could be in HIV, hepatitis C infection, and different malignancies. You can include one more, basically, which is a type of secondary that is called as drug induced, because certain drugs, they can also destroy. These are the list of the drugs you can see. Okay, they destroy platelets, and what happens, like the patient can develop thrombocytopenia. So what happens is, any patient who have immune thrombocytopenic purpura, what happens is, like, all the newly cases diagnosed, we call them as acute cases, less than 3 months. If the condition is running for more than 3 months, we call that condition as persistent. Now the condition is persistent. Okay, so less than 3 months. All right. So less than 3 months is acute, and after that, less than 3 months is called as acute condition, and when the condition is like 3 to 12 months, we call this condition as persistent. Okay, and anything which is running chronic is more than 12 months is called as chronic. Okay, so simply, there is antibodies against the platelets which bind to the platelet surface, and there is increased platelet destruction. Okay, and what will happen in these patients, like simply bleeding, petechias, purpuras, mucosal bleeds. We had discussed this thing in the previous lecture. The most feared thing which we always, what you can say, feared of is intracranial bleed. Okay, that is the most dangerous thing which should not happen in these patients, is intracranial bleed. Okay, this one is like really dangerous. Of course, like this one is going to cause a lot of more damage to the patient. So what are the investigations can be done in these patients? Of course, this is conjunctival hemorrhage, and this one is intracranial bleed. So investigations, of course, we go for CBC. We found thrombocytopenia. Okay, what happens next is, we can check PT and APTT. And if you know what is PT and APTT, PT and A activated plasma prothrombin. So prothrombin, of course, like in this one, they depend on what the clotting factor. So of course they will come back as normal, because this one is like the problem of primary hemostasis, not secondary hemostasis. So if you had learned listen to the previous lecture carefully, you must know, like, these one will only be disturbed when, of course, like the patient have a decreased level of what clotting factors. So they will come back as normal. Thrombocytopenia can be there. Platelet antibodies can be seen, of course. And to check for the causes, by the way, very important thing. like in these patients, I will also go for one more test. Like I'm going to do serology for HIV, uh, hepatitis C virus, all this one, because they can also cause thrombocytopenia. So we can do this thing, and depending on the clinical symptoms, you can check the vitamin levels. If you are suspecting that the patient have any connective tissue disease or SLE, for example, you can do uh, anti-nuclear antibodies in these patients, of course, very important. So we can do that, of course, like to check for the cause. Bone blood smear can be taken, or peripheral blood. We can found megathrombocytes or slightly large platelets. Bone marrow biopsy can be done, of course. In this one again, you will find megakaryocytes. Especially, in adult type of ITP, we do this kind of bone marrow aspirate. Why? Because most of the kids, the remission is on itself. So especially when you're suspecting that there is some condition like myelodysplasia, you can do bone marrow aspirate. Otherwise, no need to go for that. See, this is like they have done blood film and very few platelets can be seen in this one. Okay, and this one is like bone marrow biopsy, like increased level of megakaryocytes and all this stuff. They are showing you. Okay, so how it is treated is simply uh, most of the time, we don't go for treatment, by the way, guys. Sorry, this one should be changed. Um, I don't know what happened to the slide. Okay, so one of the things to remember here is like until and unless the count of the platelet is more than 30,000, no need of treatment. Until if the patient is bleeding, of course there is need of treatment. But if the patient is stable, there is no need of treatment. For example, if the patients they are bleeding or they are actively bleeding, then what we have to do? Emergency treatment. In that case, of course, the important thing is to stop the bleeding, right? So any patient who has active bleeding, either in CNS, um, either in GIT tract, either in genitourinary tract. So of course, like we have to do something urgent so that the bleeding should be stopped. So in that case, what we do, we give them high dose corticosteroids. Okay, prednisolone can be given, dexamethasone can be given, and we give them anti-fibrinolytic drugs. One of a drug which will come again and again, it is called as tranexamic acid. Okay, especially if there is mucosal bleed, we can give them intravenous immunoglobulins. Very important. If we can give them intravenous immunoglobulins. Platelet transfusion is reserved for any bleeding which is not stopping. Okay, or for refractory bleeding or very major bleeding, or someone who needs surgery. Why? Because if you will give platelet to any patient who have immune thrombocytopenia, of course, like the immunity is going to destroy the platelets which you are giving. So there is no point of giving. So platelet transfusion is only given when the bleeding is not stopping by other ways, or for example, the patient have to undergo some urgent surgery. Okay, so then we infuse transplant platelets, so that there should be immediate effect we can get. So this is how we treat. And the last resort, like of course, one thing which we can do is splenectomy. Of course, like all the cells are destroyed in the spleen, so we can do splenectomy, of course, like so that like the platelet should not be destroyed. Okay. So this thing is like the emergency treatment. Otherwise, the treatment is only needed, uh, especially when the what you can say level of platelets go under 20,000. Okay, so start treatment if the level is below 20,000. Okay, so this is a very important point. So whenever we treat, by the way, these patients, what we do is like there is a first, steroids are considered as the first line drugs. Okay, these are the first line corticosteroids. We give them dexamethasone, prednisolone, whatever. Intravenous immunoglobulins are also considered as first line drug. This is also first line. Okay, so it's also first line drug. Intravenous immunoglobulins we can give. So this thing. So for example, and all this one, of course, like spleen, of course, if the patient cannot, okay, after like if someone who cannot take corticosteroids, of course you can give them some immunosuppressants like these drugs. Okay, remove spleen or splenectomy is basically a second line treatment. Okay, if the patient is not getting cured or relief or remission by this treatment, we can go for splenectomy. Okay, this is important. And then there is some other medications. For example, one thing is called as TPO or thrombopoietin. Okay, it is also called as TPO. So thrombopoietin receptor agonist, sorry, not antagonist. So thrombopoietin receptor agonist can be used. Like there's a drug called as romiflostin. Okay, this can be given. And of course, like this is all what this is all you can say immunosuppressive drugs, right? These all are immunosuppressive drugs. So all these immunosuppressive drugs, they are considered as third line, of course. Even this is third line, so this one should come here. By the way, this one should be here. All these are third line, which I'm writing below this. Okay, all these treatments are third line treatments, you can say. Azathioprine or cyclophosphamide or vincristine or danazole, all these drugs are immunosuppressants. So simply, like, we keep on treating them, we keep on checking the response. How you will check the response? You will keep on checking the platelets, if the platelets are increasing or not. If the platelets are increasing for more than 100,000, of course, response is there. If the platelets are between 30,000 to 100,000, so it means there is partial response. But if the platelets stay below 30,000, it means like there is no response of the treatment. So I already told you, like most of the babies ITP, like childhood ITP, like it can be, there is a spontaneous remission. 80% of the cases, they go into remission themselves. No need of any active treatment. But most of the adults, of course, they need treatment. So this condition is not so dangerous, guys. Like it's like most of the patients, they stay safe, they stay healthy. It's a benign type of condition. Okay, just like as the patients they get old, there is increased risk of bleeding. So that is the major concern we have in these patients. So this is like all about ITP. And then we will talk about one more thing called as heparin-induced thrombocytopenia. So it have basically two types, type 1 and type 2. Okay. So as you can see the name, like when we start someone with heparin, what happens, like there can be thrombocytopenia. Okay. So previously, like it have two types. Previously, they were called as type 1 and type 2, HIT, H-I-T, heparin-induced thrombocytopenia. So if you will see, the short form is HIT, HIT, heparin-induced thrombocytopenia. Before it was called as type 1 and type 2. Now they changed the name. Now type 1 is called as heparin associated thrombocytopenia. This is previously type 1. Okay, previously they called it as type 1. Nowadays it's a new name. And type 2 nowadays is called as heparin-induced thrombocytopenia. Okay, previously it was called as what? Type 2. So very very easy concept. It's immune mediated. Okay, it's immune mediated. What happens? Antibodies recognize the heparin. Okay, so when they recognize the heparin, they activate the platelets. Okay, and they activate the coagulation system. Simply, when we give heparin to any patient, it recognizes, like the antibodies recognizes heparin and platelet factor 4. Okay, and they lead to the activation of platelets, and or in other words you can say the activation of the coagulation system. So what happens is when they activate uh, the coagulation system, so there is risk of thrombosis. Okay, what is there? There is risk of thrombosis in the patient. So what happens? See, simply anyone who have hit, so what they can have, because it is activating the coagulation system. So they may have deep venous thrombosis, they may have pulmonary embolism. Okay, they may have for example pulmonary embolism, they may have cerebral sinus thrombosis. Okay, they may have, you can say, myocardial infarction, very important. They may have what, a stroke. Okay, all these things, of course, like they start uh, what you can say, due to hypercoagulation or coagulation. So this is the thing, the important thing in these patients, like they don't bleed, right? They go into hypercoagulation, immune mediated, because the antibodies, when they recognize heparin and platelet factor 4, they activate the coagulation cascade. So what happened is, like, there is increased risk of thrombosis. Okay, there is one more thing called as heparin induced skin necrosis when we give low molecular weight heparin. So they present with the patient, sometimes they present with fever and chills and flushing when they have this thing. It is also called as acute platelet activation syndrome, but like not so important, guys. Like, and I don't think so anyone will ask you things like this. So how we can diagnose this? So of course, like, the patient will be having history of receiving heparin just now. Okay, so what we can do, we can do ELISA. Okay, to catch that antibodies, so we can do ELISA in these patients. Okay, and basically it takes 5 to 15 days. Okay, to start like this. So the important thing here is, like, I don't know, like, how many of you want to go in more detail of this one, but of course, like, this is a little difficult to understand condition if you don't know the clotting cascade completely. The introduction which I gave you, of course, is to make you understand the basics. Okay, so of course, like, what should be the treatment? It is done by heparin. So stop heparin as soon as this thing is recognized. Stop heparin, and whatever you are giving, like uh, low molecular weight heparin, whatever you are giving. Okay, so and once you stop that, so what is going on? Thrombosis. So initiate anticoagulation. Of course, we don't want that. Okay. So why we are initiating anticoagulation? Okay, because we give heparin for anticoagulation. Okay. So now, see, heparin-induced thrombocytopenia is causing thrombocytopenia, but the patients, they are not at the risk of bleeding. Rather, there is risk of thrombosis. Okay, well, like heparin will cause thrombosis, not bleeding. I think like this is a very important thing to understand. Okay. Oh, by the way, I should write over here just to make you guys. Bleeding complications are not common in this one. Okay. There is thrombocytopenia, but people don't believe, but rather people go into um, risk of thrombosis. So why we give heparin? Of course, we give heparin to start anticoagulation. For example, in myocardial infarction patients. So there are many alternatives to heparin. For example, erga, trebon. I'm sorry with the spelling if there is any. Danaperoid. Danaperoid can be given. Okay, fondoperinox, and there are many drugs. Okay, which is used. Okay, which can be used, and we give these drugs for 2 to 3 months to these patients. Okay, so this thing, this is the condition. So it have two types. I told you. Type 1 is nowadays called as heparin-associated thrombocytopenia. And what happens in this one? There is directly, you can say, heparin-mediated platelet aggregation. Okay, it's a non-immune condition. Type 1 is a non-immune condition. It's a non-immune condition. That's why they had made a different category. And in this one, the platelets, they stay more than 100, and it is self-limited condition. And in type 1, basically, that's why I write heparin-induced thrombocytopenia above. Okay, and before it was like type 1, type 2, but now they name it as a different one. They call this one as heparin-associated thrombocytopenia because this condition is non-immune, whereas heparin-induced thrombocytopenia is an immune-mediated condition. And in this one, there is no risk of thrombosis. Okay, whereas in heparin-induced thrombocytopenia, there is risk of thrombosis. Okay, so in this one, whenever the patient have this condition, we don't stop heparin. Okay, so I should remove it from here. Okay, because that is written above, by the way. Okay, so remember guys, this one, okay, I will fix it just to make you guys not confused. Okay, so like after this, I'm putting it down because nowadays, like, this condition is different. Okay, so there is no risk of thrombosis. We don't stop heparin. Whereas in a heparin-induced thrombocytopenia, which is previously called as type 2, is immune-mediated. Again, there is thrombocytopenia, but there is risk of thrombosis. So of course, in this one, in heparin-induced thrombocytopenia, we stop heparin. Okay. So this is the difference between this thing. So there is a clinical scoring system as well to check either anyone is having heparin-induced thrombocytopenia or not. But again, I don't think so. Like, we must go in more detail for that. Okay, hemolytic uremic syndrome we have already covered. There is one more condition that is called as thrombotic thrombocytopenia, penic, purpura. Okay, see, I'm writing because I have already explained HU has hemolytic uremic syndrome. If you remember, I told you that they have infection from E. coli. The toxin go into the what you can say, the intestines, and the toxins are released, and what happens, like, it causes a lot of what you can say, microangiopathic hemolytic anemia, if you remember. Then those toxins, they go to the kidney, they causes Kidney damage, what can happen? Acute kidney failure or renal failure. It will destroy platelets. Thrombocytopenia will occur. Bloody diarrhea can occur. Okay, all these things. So what is the difference between Hus and what is the difference between Hus and TTP? Hus, basically, we study Hus in relation to what? Pediatrics. This one occur in peds, in babies. This one occur in adults. Okay. So let's make, like, you can say, two sections over here. First of all, I will try to see how to make two sections over here. Okay, wait, I know. Sorry. Okay. Wait, guys. Just design. Okay. I'm really sorry, I'm still mastering. Yes, I found it. Finally. Yes. Okay. So now, what we are studying, we are doing thrombocytopenic purpura. Okay, this one is for Hus, this one is for TTP. Okay, so what I told you, Hus, children, and what I told you about TTP, it is adults. Okay. In this one, if you remember, it occurs by E. coli, right? E. coli, or it can occur by other infections as well. I'm just writing E. coli, okay, and other infections or oblique drugs, okay, just to make it fully. This one is basically, there is deficiency of what is this? Okay, wait, adults. There is deficiency of metalloproteinase. Okay, now what is this metalloproteinase? Basically, these are the enzyme which break von Willebrand factors. Okay, so it can be congenital, it can be acquired. Acquired means caused by drugs or cancers and AIDS, for example, or it can be idiopathic. So this one basically destroy the ultra large von Willebrand factors which are present in our blood. Okay, so when this one cannot destroy them, simply when these von Willebrand factor is released by what von Willebrand factor is released by what? Endothelial cells. So von Willebrand factor is released by endothelial cells, and when like they are, you can say, basically they are cut into small pieces by our enzyme, okay, which is a protease enzyme. It have a big name, ADMTS13. Okay, so when it cannot be destroyed, okay, so what will happen, that they are going to cause the same thing, like MAHA, thrombocytopenia, okay, and all this stuff. If you remember in this one, what we have studied, like in this one is like, in this one, what is the condition is like, there can be MAHA, thrombocytopenia, right? There could be acute kidney injury, there could be bloody diarrhea, okay, if you remember from what we have already studied. Now the thing about TTP, you have to know When one Willebrand factor cannot be broken into small things, see, they will cause the same thing: MAHA, microangiopathic hemolytic anemia, thrombocytopenia. Okay, but what make this thing different from HUS is it have neurological features. These patients are present with headache, seizures, confusion, okay, things like this. So this is the only thing, you can say, which will differentiate that thing with other one. Okay, uh, rest is everything same. What we can do to diagnose these patients? CBC we will do, right. In this one we will get decreased platelets, for example. We will do PT and APTT. They will be normal, of course. Why? Because will come back as normal because the coagulation factors are normal, right? There is no what you can say. There will be no abnormality in that, and of course, then we will get bilirubin will be raised. Why? Because there is hemolysis going on. LDH will be raised. Okay. Why? Because there is hemolysis going on, and haptoglobin will be reduced. Why? Because there is hemolysis going on. Like we had already done these things. Okay. If you will try to check like either it's some sort of immune type of mechanism is going on, you can do Coombs test, but Coombs test will be negative, right? It will come back as negative. And of course, like acute kidney injury will be there, so it can lead to increase urea and creatinine, all this stuff. So this thing, I will not write more features about HUS because we have already done this thing. But what you can say, we can make the confirmed diagnosis by doing ADAMSTS-13 gene, okay, which is the one which will give us the diagnosis of this condition. So, of course, guys, this condition is medical emergency. Remember this thing, because the patients can die, and what will happen, what we do in these patients is like we provide them with steroids, plasma exchange therapy can be done, okay, and what will happen, like plasmapheresis can be done, okay, and the mortality is very high because the people, they can start bleeding, they have neurological symptoms, okay, and there is microvascular thrombosis going on because the big one Willebrand factors, which cannot be broken down. So of course, like they can block, and they can cause different conditions. So simply, there is microvascular thrombosis occur in these patients, and they can bleed. So it's a medical emergency. Plasma exchange therapy, plasmapheresis, steroids, all of them they are given just to tackle the condition. I already talk about von Willebrand disease. Like, what is that, by the way? It's an inherited bleeding disorder. It's not so common, but it's autosomal type, dominant type of condition. And von Willebrand disease, von Willebrand disease. Like remember, it's inherited in autosomal dominant inherited, okay, way simply. So most commonly, women are diagnosed with this condition, and how they are diagnosed, because they have heavy menstrual bleeds, okay, which occurs in women, and then they are diagnosed with this type of condition. So there are different types of this thing. I'm not going to go in detail of that, of course, like it's not needed. And what is the function of one Willebrand factor? It is released by endothelial cells, and the platelets are the one which come and attach to them. So um, when the von Willebrand factor will not be there, so what will happen, that simply the platelets will not attach, and if you remember what we say, that thing as adhesion is not going to occur. Okay, so adhesion will not occur, aggregation will not occur. So simply when these things will not occur, so simply there is problem with the primary as well as the secondary hemostasis. So both, you can say, primary and secondary secondary hemostasis is affected, right? They will be affected, of course, both of them, because no aggregation, no adhesion. So of course, like, we need the platelets to get aggregated together, and then of course fibrinogen will be changed into fibrin, and the patient will be like the bleeding, the clot will be formed, of course. So as we were discussing in TTP, like, there is big von Willebrand factor, uh, you can say, molecules, of course, in the blood, which should be broken down to smaller one, so which is called as multimers. Okay, so basically these large multimers are the most active in, you can say, initiating the platelet adhesion and aggregation. Okay, so this thing, and like, many people, they have what you can say mild disease, and many people, they have severe type of disease. Basically there are three types: type 1 and type 2 and type 3, like involve one Willebrand disease. Okay, so in my type 1, there is a mild, you can say mild, very small amount of quantitative, like the you can say the quantity is decreased. Okay, so most of the patients, this is the most common one, most common type is with this one. Mostly people who have one Willebrand disease is like having this type. So it's a quantitative, so small amount of one Willebrand factor is deficient. Okay, so in type 2 there is qualitative, like the quality is not fine, quantity is okay. So you can say in this one the quantity is decreased, the quality is little affected. In this one, quality is more affected, quantity is less affected. Okay, so this one is, and type 3 is like total absence, you can say. Okay, total absence of one Willebrand factor. It is the rare most one. So simply these patients will present with bleeding history, guys. Simply, if you know the function of Willebrand factor, you can tell like what will be the features. They present with bleeding history, and of course, like, and what kind of bleeding, because it's primary hemostasis. So remember, superficial bleeds or mucosal bleeds or epistaxis or a heavy menstrual blood flow. Okay, mostly diagnosed in women. Okay, so bleeding history, and if you know what kind of bleeding: primary hemostasis, superficial bleeds, mucosal bleeds, epistaxis, menstruation, petechias, purpuras, ecchymosis. Okay, so superficial bleeds simply, most of them. How to investigate? Again, the same thing. You will check CBC, you will check platelets level. Platelets are normal. Okay, so it means there is some other problem. So when platelets are normal, what is the two main players in primary hemostasis? It is platelets or one Willebrand factor. So if platelets are normal, you must go and check one Willebrand factor. So when you will check one Willebrand factor, of course, uh, we can diagnose the condition. Okay, so we can check one. I'm just writing what you can say targeted investigation. I'm not writing all the investigations. Okay, you can check one Willebrand antigen. Okay, just to check like how much one Willebrand factor is present. Then we can check one Willebrand factor, that is called a restositin cofactor activity. Okay, so what is this one? This one will tell us how much one Willebrand factor is present. This test will give us the activity, how much one Willebrand factor is binding with platelets. Okay, and when one Willebrand factor need factor 8 to work. Okay, factor 8, clotting factor 8 simply. So one more thing which we can do is wait, we can also check the level of factor 8. Okay, because both of them, they work together, so we can check the level of factor 8 as well. So simply guys, one Willebrand factor disease, um, what you can say, we can also order all the clotting profile, by the way, but PTT will be normal, factor 8 can be normal, platelet count of course will be normal. If the activity is decreased, of course this test will be, the resorticin cofactor activity can be reduced, one Willebrand antigen will be reduced. Okay, uh, like this, right? So now, how to treat this condition? Treatment of one Willebrand factor or one Willebrand disease. It is written as small v, big W, and big D. Okay, so the treatment is very interesting. We give them desmopressin. Now, if you know what is desmopressin, DDAVP. If you remember, like this condition, diabetes insipidus, we use the same thing. Okay, this is the very effective treatment. Up to 90% of the people, they respond to this treatment. Type 1, who have type 1 disease, around 90% respond to this treatment. Okay, why? Because when we give this drug, desmopressin, it releases one Willebrand factor and factor 8 from endothelial cells. That is the only thing. When we give DDAVP to the patients, it releases one Willebrand factor and factor 8 from endothelial cells. So type 1 people, they respond very well for this condition, because when we provide them with this condition, there is more and more release of one Willebrand factor and factor 8 from the endothelial cells. So the problem is solved. Okay, so this thing is one of the treatment. Then you can say one drug which will come again and again in this one, as well as when you will study gynae, many gynecologists, they keep on writing this drug, tranexamic acid. Okay, so basically what it do, it stabilize the clot formation. It stabilizes the clot form. Okay, so of course, like this drug can be given to anyone who is bleeding. And what happens when someone don't respond to this thing? Anyone who is not responding to desmopressin, so simply we can provide them with one Willebrand factor plus factor 8 concentrate. Okay, we can provide them with this. Okay, if anyone who is not responding to this, we will, of course, like this one will increase the release of one Willebrand factor and factor 8 from the endothelial cells. But someone who is not responding to this treatment, simply, so it means like we have to provide that thing. So we can provide this thing. Okay, so this thing. So most of these are females, and most of them, they are presented to the gynecologist because of heavy menstrual bleed, and they do these investigations, and they found like the patient is as a patient of one Willebrand disease. Okay, so that's why, guys, consider this condition in any patient who is having menorrhagia. Okay, so mostly diagnosed in women. That's why I already write over here. So it's a very common, it's the most common inheritable coagulation abnormality, by the way. So gynecologists, they keep on writing this medication, okay, to the females. So this thing is important, right? By the way, whenever we give desmopressin, what happens is there is antidiuretic effect, like more and more water is retained, okay, so which can lead to hyponatremia. So remember, one of the side effect of this drug could be hyponatremia, and because of that side effect, we don't give this, like we or not we don't, but like whenever we give it to the children, we always monitor for any hyponatremia, okay. So I can write over here, by the way, very important point. Uh, uh, Cautious use in children due to the risk of hyponatremia. Okay, this is an important point. You can say, okay. So this thing is important. So most of the females, they can get this condition, and of course, like the gynecologists, they write, they diagnose, and they found this thing. Okay, this is the investigations. This is the history and breeding history. I told you what type primary hemostasis, which I in the previous lecture I made 2 sections. I told you what kind of bleeding is superficial, what are the deep bleedings. Okay, so this thing is important. So the prognosis is good with these patients, like patient with type 1 Willebrand factor. They they have a good life. They don't have anything. So, but of course, if the deficiency is very severe, so there can be the history of increased bleeds and things like this. So that's it, like what you can say about the disease of primary hemostasis. Okay, and then our next lecture will be about disease of secondary hemostasis, and in that one we will cover hypercoagulable states as well, and then we will go on to the what you can say the malignancies, right? And that's it, like once malignancies will be done, so our this unit of hematology will be done as well, okay. And then like we have to do two more units, one is nephrology and one is rheumatology. So that's it. So thank you so much, guys, for giving some attention. Okay.